Good evening, everyone. Good evening, ma'am. I'll be presenting a case of a 55-year-old female, Mrs. XYZ, who is a homemaker by occupation, who is residing at Ballari, was admitted on the 5th of April and was examined on the same day. She came with the chief complaints of tingling and numbness over bilateral lower limbs since 1 year, reduced sensation over bilateral lower limbs in 6 months, and reduced sensations over the left upper limb since 4 months. History of presenting illness. The patient, non-diabetic right-handed individual, was apparently all right 1 year ago when she noticed tingling and numbness of bilateral lower limbs. Initially, they were insidious in onset and gradually progressive. Initially involved the soles, such that the patient had no sensation over the chappals and had frequent slippage of chappals without her knowledge while walking. And these episodes have increased in frequency since the past 6 months. And she also complains that she feels a cotton-like sensation while walking over her soles since the past 8 to 12 months. This sensation, the tingling and numbness, progressed gradually such that they involved currently up to the knee. And the patient attenders noticed multiple traumatic wounds for which the patient was having an infection and discharges and was treated at a local hospital with antibiotics and local dressings. And they healed well. Each wound took about 5 to 7 days to heal. There is no diurnal fluctuations or any falls that the patient noticed at night. The patient denied any pain at the onset, of these symptoms. Following which, the patient also developed reduced temperature sensation over bilateral lower limbs in 6 months. Insidious in onset, symmetrical at onset involving bilateral lower limb. It gradually progressed to the current state, such that initially patient was unable to appreciate hot or cold while washing the feet, and which progressed such that patient is unable to sense hot or cold sensations up till the knee. There is no any bowel or bladder involvement at this stage. There is no history of low back pain, band-like sensation. There is no history of swelling of the limbs or any difference in the color that the patient noticed of bilateral lower limbs. There is no history of pain in the limbs or difficulty in walking or claudication pain. There is no history of thinning of the limbs, skin change or itching. Skin color change or itching. 1 month later, the patient also noticed reduced sensation over the left upper limb, such that it was insidious in onset, initially involving only the digits, involving all the 5 digits, progressed in such a way that it is currently involved up to the mid-arm. Patient was unable to appreciate pain, temperature or touch in the upper limb. Also, the patient noticed there is a lightening of the skin associated with some hair loss in the upper limb. Patient is not clear about the loss of sweating. However, the attenders also noticed some multiple whitish lesions over the skin, predominantly in the lower limbs as well as in the trunk. And this is associated with some loss of sensation. Each patch was about 1 by 1 centimeter with no progression, which were non-pruritic in nature. And they were associated with loss of sensation, and they were noticed since 5 months. There is no increase or decrease of these lesions over the past 5 months. There is no history of any loss of consciousness or trauma or weight loss. There is no history of stiffness of the limbs, no history of neck pain or shock-like sensation. There is no history of difficulty in holding objects, mixing food, eating or combing hair. There is no history of difficulty in walking or swaying while walking. There is no history of suggestive of any cranial nerve involvement. There is no history of this motor weakness that the patient complains of. There is no history of involuntary movements, no history of weight loss, weight gain, no history of swelling or limbs, increased frequency of urine or nocturia, no history of rash, arthritis, photosensitivity, reduced urine or headache. There's no history of reduced tears or increased burning in the eyes. No history of intake of any drugs. And there's no history of discoloration of teeth or nails or any bowel or bladder disturbance. She's born out of a non-consanguineous marriage with no similar complaints in her family members. There's no history of diabetic, hypertensive, tuberculosis, epilepsy, or thyroid disease in the family. There's no previous hospitalizations, and patient took only treatment on an outpatient basis. She underwent regular local dressings for the wounds. However, she never developed any fever during any of these episodes. No, she's not a known diabetic, hypertensive, epilepsy, asthma, or thyroid disorder. She consumes a vegetarian diet. Her appetite is normal. There is no disturbance in the sleep pattern or duration, with bowel bladder sensations being regular, with no deleterious habits.
So we'll start from the first symptom. No?
Yes,
you told that there is tingling and numbness. No?
Yes, ma'am.
Started in the both lower limbs symmetrically. No?
Yes, ma'am.
So what do you understand by that term you want to discuss? Huh?
So, yes, ma'am. It indicates a positive sensory symptom. So a positive sensory symptom indicates an irritative lesion or an inflammatory lesion, or a demyelination happening at the level of the peripheral nerve. So coming to the localization, it can be at the level of the peripheral nerve, or it can be at the level of the nerve root, or at the level of plexus.
So this patient is having a tingling sensation. So as you rightly said, it is a positive sensory symptom.
Yes.
Positive sensory symptoms are irritating, generally irritating.
Yes.
Other what are all the types of positive sensory symptoms we find, and to what category we will put it? That is the first question. So definitely it is a positive sensory symptom. So what it is pointing to? So you have got paresthesias, you have got dysesthesia, you have got hyperalgesia, you have got hyperpathia. These are the common positive sensory symptoms.
Yes, sir.
So what does all these mean? So we first find that our patient is having a positive sensory symptom. So into what category? Paresthesia, dysesthesia, hyperesthesia, or are you going to put it as a hyperpathia, or some spontaneous pains, lightning pains? So many things are there. Into what we are going to put? So paresthesia. So what is paresthesia? First we'll ask. So paresthesia is sensory perception in the absence of sensory stimuli. I am audible?
Yes, ma'am.
What happened? I don't know. I have not muted it anyway. So paresthesia is sensory perception in the absence of sensory stimuli. So this patient is getting that sensory perception in the absence of any sensory stimuli. Whereas what is dysesthesia? Dysesthesia is altered perception of a sensory stimuli. So dysesthesia, sensory stimuli is there, but it is perceived in a different way. You touch the patient and he says that you pricked him. So that is altered perception of a sensory stimulus, dysesthesia. What is hyperalgesia? Hyperalgesia is lowered threshold for sensory appreciation. So even mild touch, you pressed very hard. So that is the hyperalgesia is lowered threshold for sensory appreciation. Third is fourth is hyperpathia. Hyperpathia is typically seen in thalamic lesion. You have got elevated threshold for subthreshold stimuli and exaggerated perception for beyond threshold stimuli. So when the subthreshold patient, I am not feeling. So you will think that patient is not appreciating and you try to increase the pressure or the touch, then he will howl and say, you pricked me very deeply or you pressed me very hard. That is hyperpathia. Combination of elevated threshold for subthreshold stimuli and exaggerated perception for high threshold stimuli. That is hyperpathia. Then what is spontaneous pains, lightning pains, thalamic pains? You see, thalamic pains are peculiar, spontaneous, persistent, burning sensation in one half of the body. That is called thalamic syndrome of Digerin. Or you have got lightning pains. Lightning pains are pains that strike spontaneously across body planes. They do not respect a nerve or a root or a tract distribution. They will strike across the chest or across the abdomen. So you will mistake that aortic dissection, or you will think that patient had an MI or a peptic ulcer perforation. So that kind of thing is lightning pains. They do not respect the neuronal distribution. They suddenly strike across body planes. So that is lightning pains. So now our patient is saying spontaneous, so we know it is paresthesia. So what are all the types of paresthesias you can get? So sensory perception in the absence of sensory stimuli is what our patient is having. So what kind of paresthesia? The type of paresthesia may be burning paresthesia, tingling paresthesia, or a feeling of cold or feeling of heat. These are the various paresthesias. So tingling paresthesia generally indicates, so paresthesias are due to uninhibited small fiber activity, either due to irritative disease of the small fiber or destructive disease of the large fiber. So either a large fiber destruction or an irritation of the small fiber results in tingling paresthesia. Whereas burning paresthesias or feeling of cold, they always come from the irritative disease of the small fiber. Tingling paresthesia is uninhibited small fiber activity due to irritative disease of the small fiber or destructive disease of the large fiber. Whereas feeling of burning or feeling of cold is always due to irritative disease of the small fiber. So your person has tingling, so it will be either an irritative disease of the small fiber or a destructive disease of the large fiber. That is what is the analysis of the first symptom, paresthesia. So paresthesia is uninhibited small fiber activity due to irritative disease of the small fiber or destructive disease of the large fiber. Whereas dysesthesia is neuronal crosstalk. Dysesthesia means a sensory stimuli is applied, so patient interpreted faultily. How it is happening? One fiber is destroyed and repair has started. So when repair is taking place, supposing one pain and temperature fiber is repaired by a touch fiber. When you prick the patient, patient will say you touched it. Or reverse, your touch fiber is repaired by a pain and temperature fiber. You touch the patient, you will say you pricked it. So that is called a neuronal crosstalk. That is because one type of nerve fiber is talking to another type of nerve fiber. For example, supposing a cardiologist is coming to a neurology OP, for helping the neurologist, or vice versa, depending on your specialty. Anybody who throws a seizure, your cardiologist might want to investigate for an arrhythmia, or stroke, atom attack, so many things. Whereas neurologist goes to the cardiology OP, he will investigate all MIs as seizures. It's like that. So that is neuronal crosstalk. So one type of fiber being repaired by a qualitatively different fiber. So even though the peripheral stimuli is of one kind, the perceived stimuli is different. That is dysesthesia. What is hyperalgesia? Hyperalgesia is lowered threshold for sensory appreciation. That can be due to neural mechanisms, chemical mechanisms or psychological mechanisms. For example, if you have burned your fingers some time back, psychologically, even before reaching the candle or fire, person starts experiencing the suffering. So that is psychological. Whereas chemical may be, supposing you have got slow reacting substance of anaphylaxis or substance P, pro-inflammatory cytokines. No? So at a site of an abscess or injury, all these things are there. Chemical mediators of pain are there. So even if you slightly touch over an abscess, patient will feel severe pain. It is only a small touch. That is because of the inflammatory mediators which serve as pain lowering agents. Substance P, slow reacting substance of anaphylaxis, opening up of potassium channels, like that, so many things, and pro-inflammatory cytokines. All this, that's a chemical. Then neural, as you know, in the pain pathway, always the pain fibers are modulated by the non-pain fibers. For example, you have got A delta fiber and the C fiber. C fiber is a naked pain fiber without any myelin. A delta is a moderately myelinated, fast conducting fibers. And in the peripheral nerve, A delta fiber is inhibiting the C fiber. C fiber is continuous transmission of painful sensation that is inhibited by the A delta fiber, and both the pain fibers are inhibited by the proprioceptive fibers. So only what is important is sent from the peripheral nerve. In the then it goes to the spinal cord. In the you have got a gate control theory of Melsack and Wald. So there is a second level of gating in the substantia gelatinosa of Rolandi, where again a little more of unwanted, constant, persistent sensations are filtered. Only what is happening on and off and which needs to be addressed is sent back. And then again inside the Rexed laminations, you have got lamina 2 and lamina 5. They have endorphins and substance P. So they chemically modulate each other. And again, based on the amount of substance P or endorphin, something is sent off, something is filtered off. Then they ascend through the spinothalamic tract. And the spinothalamic tract is constantly inhibited by the posterior column. So to remember that, you can know that intractable pain in cancer patients, a painful cancer which is inoperable, you need only pain management. One of the treatment method is dorsal column stimulation. You implant electrodes in the posterior column and stimulate, so the pain appreciation reduces. So dorsal column stimulation, so posterior column, when it is stimulated, it inhibits transmission through the spinothalamic tract. Then these tracts ascend in the spinal cord, they reach the thalamo-mesencephalic junction. When they reach the thalamo-mesencephalic junction, you have got the periaqueductal gray in the midbrain, and that periaqueductal gray contains endorphins again. You know about the presence of endorphins in the periaqueductal gray. That again filters off some more unwanted pains. Then these pain transmitting fibers organize into thalamic component, subthalamic component, and limbic component. 3 components: thalamic, subthalamic, limbic. Thalamic component goes to the sensory cortex for association of the, for appreciation of what is that. Is it a prick or a touch or what happened? So that goes to the sensory cortex. Subthalamic component goes to subthalamic nucleus and the motor cortex. Why? So if it is a painful, why you should appreciate pain? You have to protect the organism. So for producing the motor activity to protect it, the second thing goes to the motor cortex. What is the limbic component? Limbic component is the affect. So that goes to the limbic structures, where depending on the thing that caused the pain, if it is a cancer, then a person will be very depressed and upset. Supposing it is a war wound, you are very happy, no? If it is some plastic surgery, the person is again happy, no? So those kind of limbic component is added by the So this filtering mechanism. So what is the chemical mechanism I told, and what is the neural mechanism? Altered modulation. At any time, if the modulation fails, again there is hyperalgesia. So if any of these modulatory fibers, posterior column is destroyed, so you get more pain. So that is modulatory phase. So chemical, neural, and psychic. This psychic is based on the reward and punishment. All of us work based on the reward and the punishment system. So if whatever stimuli you are undergoing is going to give you a reward, then that will be experienced as a pleasure. And if it is going to be punishment, it is experienced as pain. So that is hyperalgesia. So our patient has a paresthesia, and that paresthesia is of tingling nature. So he either had a irritative diseases, the small fiber, or destructive diseases, the large fiber. So what is the distribution? As you correctly said, it can come from the peripheral, it can come from the root, it can come from the plexus, or it can even come from the cord. Anywhere it can come. But in this patient, it is distal and symmetrical. So it apparently seems to respect a length-dependent pattern. So length-dependent pattern. So it may be peripheral nerve. One possibility is peripheral nerve. Second, another distal symmetrical can happen in posterior column. That is pseudo-neurotic presentation of a posterior column disease, we call it as. So that we have to examine, then only you will know. So apparently it looks length dependent, so it may be a peripheral nerve. It has come up to the knee, after that only it is going to the upper limb. So it can be a peripheral nerve. Second, it can be a posterior column. Posterior column can present with a glove and stocking. Apart from the many other patterns, girdle sensation, lightning pains, Lhermitte sign, deep boring paresthesia, and glove and stocking type of paresthesia is a feature of posterior column. But that glove and stocking is very peculiar. It will be bizarre. In one leg, it will be up to the ankle, and in another leg, it may be up to the hip, like that. So it can have a bizarre pattern. And when we examine, we may be lucky to find out dissociation between vibration, movement, and position. Because in the posterior column, there is a ventrodorsal lamination. Vibration is ventral, movement is middle, position is dorsal. VMP it is called. Vibration is ventral, movement is middle, and position is dorsal. So depending on which part of the posterior column is involved, one may be worst affected, other may be preserved, which will never happen in the peripheral nerve. Only if it is getting involved in the column, gross dissociation between vibration, movement, and position can happen. So one is bizarre pattern. Second, dissociated involvement between vibration, movement, and position. And third is preserved reflexes. If it is posterior column, reflexes will be preserved. If it is peripheral nerve, reflexes will be lost. So these points we can say whether it is coming from the column. Sometimes instead of that bizarre, it can be symmetrical also. So olden days, this cervical canal stenosis, which runs in families, used to be called as a degenerative disease, producing a myelopathy and a neuropathy. Later, people understood that it is canal stenosis, which runs as a dominant thing. Apert syndrome, that's a cranial stenosis. And you can have cervical canal and lumbar canal stenosis. So both are stenosis, means it will look like a myelopathy with a peripheral neuropathy. But it is actually column. But when these people were decompressed, everything was disappearing. Then only people knew, even though it is inherited, dominantly inherited, what is the glove and stocking is due to compression, not due to the neuropathy. Those days, electrophysiology, all those things were not developed. So that time running in family. So people have thought it is myelopathy plus neuropathy. And these clinical signs were not appreciated. And by decompression, they understood that it is not neuropathy, it is compression. So that is what. So this looks like that is the first symptom. Second thing, you said that the symptom after 6 months, patient started slipping of chappal, no? Or at that time only he is slipping chappal? Walking over cotton. So what is walking over cotton? So first is a paresthesia. Later, he is getting a dysesthesia. So walking over cotton is a dysesthesia. When you are walking over the floor. That stimuli is there. So that stimuli is looking like a cotton. So what is the very important thing? So first is paresthesia. Next is dysesthesia. So dysesthesia indicates whatever is the problem, your patient has got some kind of repair mechanisms. So it's a very, very vital clue. So presence of paresthesia along with dysesthesia indicates that it's a repairable disease. So it is giving a very vital clue that supposing this person has had this symptom for 15 years. You will have to think of hereditary conditions, no? So where repair never occurs. So in hereditary conditions, you never get positive symptoms. You never get features of repair at all. So that is a very important clue. Repair mechanisms are started. Dysesthesia means repair is taking place by functionally different sensory fibers. Repair indicates it's an acquired condition. So second symptom is giving a very important clue that it is acquired. It is not an inherited condition. It's an acquired condition. That is the important clue. Again, we do not know whether it is at the nerve or column, but dysesthesia generally does not happen in the column. So with the onset of dysesthesia, it looks like an acquired peripheral nerve disease. Next, slowly progress up to the knee. So multiple traumatic wounds you have written. Was it due to falls?
No, ma'am. It was, she didn't notice. The attender said I used to have this multiple thorn pricks that the patient had.
So thorn pricks because of thorns available in the environment.
Environmental thorns.
Okay. So she did not know the thorn pricks.
No, she didn't know.
So that means pain fibers are more involved. So thorn pricks not appreciated. Thorn prick not appreciated at all. That means it is probably an irritated disease of the small fiber to start with, maybe. So we from the thorn pricks we get a third point that this is probably a small fiber onset. The disease is probably small fiber onset because thorn prick is not appreciated. So here these wounds in a person with a peripheral nerve disease can be of several types. One is a trophic ulcers. So patients who get trophic ulcers, that is without prick. This is a traumatic, without any injury. Spontaneously blisters come and they heal, they get infected and they heal. They are the trophic wounds. So these conditions associated with the trophic ulcers are termed by what condition, ma'am? Acrodystrophic neuropathies. They are called acrodystrophic neuropathies. So if it is spontaneous, so skin ulcers can be spontaneous, that can result in disfigurement, autoamputation, and that group is called acrodystrophic neuropathy. Under acrodystrophic neuropathies, you have got hereditary sensory neuropathies. Then you have got porphyria, you have got amyloidosis, syringomyelia, Hansens disease. These are all acrodystrophic neuropathies. So this is not acrodystrophic neuropathy. This is a prick-induced wounds. Prick is producing the wound because the patient is not appreciating. So that is unappreciation of pain sensation. One is the trophic ulcer, which it is not. Here it is unappreciation of pain, indicating that it's a small fiber that is affected. Third kind of skin ulcers are happening with the vasculitis. Vasculitic neuropathies. Vasculitic neuropathies are also small fiber neuropathies. Supposing you have got a demyelinating neuropathy, it will be a proprioceptive fiber. Myelin-rich fibers are proprioceptive fibers and the motor fibers. So last only will be the pain fiber. So, pain fiber last is a typical feature of demyelinating neuropathy. First will be proprioception and motor. But your patient is having pain first. So vasculitic neuropathy we cannot rule out. So it can be vasculitic neuropathy. So what you get typically in vasculitic neuropathy is painful punched out ulcers. They are called painful punched out ulcer. This is a painless ulcer. So this is a painless ulcer, trauma induced. They are painful, spontaneous punched out ulcers. They are extremely painful. They are like you have punched it out because of the infarction of the cutaneous vessels. In vasculitis, the cutaneous vessels produce skin infarction. So that infarcted skin is removed like a punched out skin. So they are called painful punched out ulcers. So it is not a painful punched out ulcer. It is not a trophic ulcer. Then you get a spontaneous ulceration and wounds in conditions like without trauma or with trauma. You can get in conditions like Hansens disease. So these are the conditions. So whatever it is, this is not trophic, this is not painful punched out. This is a trauma-induced wounds indicating small fiber is involved, and small fiber neuropathy is commonly large fiber neuropathy is the commonest neuropathy we can find, but small fiber neuropathy can be with the diabetes, it can be with the drugs, anti-cancer drugs, toxic, or it can be vasculitis, or it can be Hansens disease also. So small fiber neuropathy, now with the increasing symptoms, first we knew it is a paresthesia, so irritative disease of small fiber or destructive disease of large fiber, we thought so. And next we found dysesthesia in our patient. So presence of dysesthesia indicated that repair is taking place. It's not an inherited neuropathy, it's an acute neuropathy. And the third symptom you are getting is a small fiber is the first one to be involved. So DD becomes narrow and narrow. Is it diabetic? You said he is not a diabetic. So that is not there. So it can be toxic neuropathy. You can ask whether the patient took any anti-cancer drugs or any other drugs for a long time which can produce small fiber neuropathy. Is it vasculitis? We don't know. Is it Hansens? We will keep these two questions alive. So that is the information from the third symptom. No diurnal fluctuation or faults at night. Again confirms that the proprioceptive fibers were not involved. What is the next symptom? No history of pain. Insidious symmetrical onset gradually. Then it involved temperature. No? So first thing to be involved is the pain fiber. Next to be involved is the temperature. Both are small myelinated fibers only. And you're initially unable to appreciate hot or cold while washing feet. Both hot or cold not appreciated. Okay. Is it helping us in some situation? Appreciation of hot or cold, both were not appreciated. No? No. So is there any differential involvement between hot and cold? It is said that Hansens disease prefers the cold fibers first, then the hot fibers. But other small fiber neuropathies do not differentiate like that. But patient, we cannot expect all that. We cannot expect the patient to tell that initially it was cold, later it was hot, unless you test in the bedside in the early phase of the disease. But patient may not be able to tell. Only when both are affected, he may be feeling. So there is a differential involvement in some diseases. So in this patient, both are affected. Again, that indicates a small fiber only. Then progress to involve the knee. After involving the knee, it went on to the right upper limb, you said, no? One upper limb. Left. Right or left?
Left upper limb.
Right upper limb is not involved.
Spared.
So in the left upper limb, you said it is all the fingers. All the fingers. And it went up to the elbow.
Up to mid-arm.
Mid-arm. So what is the pattern, you can tell me? All the fingers up to the, so it is symmetrical. No, circumferential. One thing, if it is bilateral, after it has reached the knee, it goes to the upper limb. It can be a length-dependent neuropathy. By the time knee is reached, the upper limb is involved. But in the upper limb, it is asymmetrical and circumferential. So asymmetrical indicates you cannot call it as a length-dependent neuropathy. So when it is asymmetrical, in the upper limb, it can be mononeuritis multiplex,
multiplex,
where the coalescing nerves So many nerves are affected in one limb. They have coalesced and look like a symmetrical peripheral nerve. So it can be coalescing nerves. It is called coalescing nerves, or it can be coalescing roots also. Multiple nerves coalesced or multiple roots coalesced. So that can produce a symmetrical. Next, sometimes you get it in tract. When there is a spinothalamic tract which is crossing spinothalamic tract, eccentrically involved on one side. So then it can produce a circumferential level. It can happen. It is mainly small fiber pavement temperature. So in that segment, you see ascending spinothalamic will produce a level, vertical level, below that everything will go. Whereas crossing spinothalamic will be suspended. So is it a suspended sensory loss involving the spinothalamic tract? We do not know. Crossing spinothalamic tract. So circumferential one limb may be coalescing nerves. It can be coalescing root, or it can be crossing spinothalamic fibers of that upper limb. These are the possibilities you have to consider when it is. Sometimes it is kind of symmetrical, that is circumferential, but one side. Not in this case, can happen in ischemic. Supposing you travel a long distance and sleep on your brachial artery. So you can get your radial nerve palsy, that is one. Then when you sleep on your radial nerve, if you sleep on your brachial artery, it is the distal most part which suffers ischemia. And as I said, demyelinating neuropathies prefer the motor fibers and the proprioceptive fibers, whereas ischemic ones prefer the pain, temperature, as well as autonomic fibers. Whereas toxins prefer pain and temperature with the relative sparing of the autonomic with some exceptions. So when this person has all this, we are not thinking that he slept on his brachial artery and had two different pathologies, dual pathology. Yeah, distal symmetrical small fiber neuropathy of the lower limb and an ischemic condition of the upper limb is a theoretical possibility. We do not, then it should come acutely following night sleep or a long travel sleep, then it should come. It didn't come like that. Instead, it progressed slowly. So you have to consider three things. Is it a coalescing neuropathy, coalescing radiculopathy, or is it a intrinsic cord lesion? So peripheral nerve with intrinsic cord involvement can happen in some situations. So whether you are going to consider cord plus nerve. These are the questions you have to ask when this is the symptom. In the right upper limb never got involved.
No, patient didn't complain of it, but on examination it was there.
So it is surprising that the right hand is the dominant hand. So everybody will complain with the right hand. And if it is there in the right and the person not complaining is very, very unusual. So, okay. So if that is not there in the history, these are the things we will consider. Okay. Then what conditions can produce cord and the nerve? Small fiber vasculitis, Sjogren's disease. Conditions like Sjogren's disease, vasculitis, because vasculitis is the small fiber I said. So vasculitic neuropathy in the lower limb and vasculitis involving the cord. So cord and root can happen with Sjogren's disease. It can happen with sarcoid, but sarcoid prefers the large fiber, doesn't prefer the small. So cord and the nerves can be involved in many conditions. One, it can be HIV neuropathy, or it can be paraneoplastic. It can be subacute combined degeneration of the cord, no? And it can be sarcoid. But small fiber cord and the root, only one condition is there, vasculitis. So small fiber cord and the root has to be vasculitis if it is turning out to be so after examination. Second, we will consider coalescing nerve. So what are the conditions where you get a distal symmetrical peripheral neuropathy and a mononeuritis? A combination of distal symmetrical peripheral neuropathy and a mononeuritis, and that too only pain and temperature. You see, distal symmetrical peripheral neuropathy with mononeuritis can happen in CIDPs, where you have peripheral neuropathy with multiple motor nerves getting picked up in an asymmetrical fashion in the chronic varieties. It can happen. But if it is small fiber, you have only one disease, that is Hansens disease. Because you can have a lepromatous with tuberculosis borderline, the crossing over types, where you have got mononeuritis as well as a peripheral neuropathy, a combination of both small fiber. That is it. If it is both small and large fiber, you have a wide variety of differential diagnosis. In this case, so far from the history, it is only small fiber. So if it is small fiber, I will consider Hansens disease as a first possibility. Okay, next one, sir. That's all. No bladder fiber involvement, you told. No bowel, bladder. Other autonomic features are there, no?
No, ma'am, no autonomic features.
Trophic changes, loss of hair, glistening skin, nothing?
He didn't complain of any.
Okay. So from the history, we will say that my patient had a positive sensory symptom to start with. It was an irritative symptom of the small fiber. There was evidence for repair, so it's an acquired condition. And there is a symmetrical small fiber involvement in the lower limb and asymmetrical small fiber involvement in the upper limb. As it was confined to small fibers, pain and temperature alone, it is likely to be a sensory, purely sensory, under which category differential diagnosis is much less. If it is large fiber sensory, you have more DDs. When it is not there, the possibility is Hansens disease from the history. We'll go to examination. We may have surprises. We do not know. As I told, if you have a cord crossing fiber involvement in the cord, a small infarct, then it can be a Sjogren's disease or vasculitis that can present a small fiber neuropathy. Okay. On examination, you tell me.
On examination, we have a middle-aged female, conscious, cooperative, well-oriented time, place, and person. There is no pyrorictus, cyanosis, clubbing, lymphadenopathy, or edema that was noticed. The blood pressure was 140 by 70 millimeter of mercury in the right arm supine posture and 136 by 70 in the left arm. There is no orthostatic hypotension. Pulse was regular, normal volume and character, with peripheral pulses being well felt. No radial or femoral delays. Respiratory rate was normal, the thoraco-abdominal type.
Thoraco-abdominal, that's normal.
Normal. Coming to head-to-toe examination, there is no loss of hair. There is no neurokeratinous markers. There are a few hypopigmented anesthetic patches over the arm and the thigh, and also few were on the trunk. There is no pes cavus. There is thickened nerves, which the palpable nerves were the radial cutaneous nerve.
Patches are looking like what? Macules are macules.
Macules.
Mm-hmm. Okay.
And this thickened nerve, which was there is the radial cutaneous nerve palpable both the arms, left more than the right, with the left ulnar being more prominent, with palpable posterior tibial nerves. The other peripheral nerves couldn't be palpable. Looked from head to toe, only these nerves were palpable. There is no Mees lines pigmentation of the teeth or Mees hole pigmentation.
The common peroneal nerve is not palpable.
No, I couldn't appreciate the common peroneal nerve.
Okay.
Coming to the nervous system examination, the higher mental functions were normal. Language was normal. Speech was normal. Memory was normal. Coming to the cranial nerve examination, the second cranial nerve, the eye, there is no madarosis. The cornea was clear. The pupils were reactive. The fundus was normal. The color vision was normal. So second nerve was normal. 3, 4, 6 cranial nerves were normal. All the other cranial nerves are normal. Specific ocular features of the disease were not present in the cranial nerve examination. The fundus also was normal. Motor system examination, there is no obvious difference in the bulk of the muscle bilaterally. Coming to the tone was normal in both the upper limb and lower limb.
Right arm is less, you have written, no?
Ma'am?
Right arm circumference is less, huh? She is right-handed person only, no?
Yes, ma'am.
15 and 40.
Yes.
If it is the dominant hand, more it is significant.
Significant.
Anyway, whether it may be something else also, it may be disuse, periarthritis, so many things can produce atrophy, but atrophy of 1 centimeter in the dominant hand is significant. You'll have to give an explanation for that, whatever it may be.
Okay. The tone was normal at the upper limb and lower limb, both flexor and extensor tone. Coming to the movements, the power, the proximal muscles were normal. Distally, the hand grip was weak. Left was more than the right. Both were reduced now, but the left was more than the right. There is no hollowing of fingers or wasting of the muscles, of the small muscles. Coming to the lower limb, the toe movements were 4/5. The dorsiflexion, plantar flexion was normal. Here there is, I put an image at the end of some skin changes that the patient also had. But there is weakness of the muscles, both in flexion and extension. Apart from that, the reflexes, there is a loss of ankle jerk with preservation of the other jerks. The supinator was also present in the upper limb. There is no loss of supinator jerk. Coming to the coordination of normal, sensory system.
The lower limb, what about, okay, you're coming to that. Okay.
Yes. Coming to the sensory system examination, there is loss of pain, temperature and pressure in the left lower limb up till the knee. And in the arm, left arm, it was lost up to 9 centimeters from the radial styloid. The complete loss of sensation, but the patient didn't have any clear-cut level at which there was improvement. In the right, in the right side, it was impaired up to the knee bilaterally. Both upper in the lower limb up till the knee, there was loss of pain, touch, and temperature. However, coming to the posterior column also was involved. It was lost up to the knee. The proprioception and vibration was lost, and fine touch. All these three were lost. Both the lower limbs and in the
column.
Yes, ma'am.
Because
like we're not able to explain this part.
Why you want to call it as posterior column? Well, column pattern is not there, no.
Yes, ma'am.
All were gone symmetrically. Angle jerk was lost, yes, and you didn't have EMP dissociation.
No, we didn't.
SR pattern not there. Angle jerk is lost. So it can be peripheral neuron itself.
So we can call it as only the vibration, touch and proprioception was lost. Should we mention it like that? No?
Vibration, movement sense is preserved.
Lost, ma'am.
Lost. That means all modalities.
All modalities.
All modalities carried by the large fibers are lost. So when the disease advances, where it started, that's what important. It started clearly in the small fiber.
All fibers.
It has gone on to involve all other fibers. In the early stage, the reflexes would have been retained. Small fiber neuropathies reflexes will be retained. But when the disease advanced in the lower limb, because it is very clear, and the upper limb reflexes are preserved. That means upper limb, the disease has not extended, advanced. So you need not call it as posterior column. You should call it as proprioceptive functions.
Okay.
It is, when you tell column, you are putting the pathology in the column.
Column. Coming to the cerebellar examination, there was no obvious signs of cerebellar dysfunction that the patient had. Gait was normal. She didn't have any limp. There was pulsion was normal. Rhombox was normal. There is no rhombox was negative.
Can posterior column and all be involved in Hansens disease? Column, spinal cord?
Can be involved, ma'am.
Upper motor neuron can be involved. All cranial nerves can be involved. Upper motor neuron can be involved, including the brain can be involved. But predominantly it is peripheral nerve.
Peripheral nerve.
Okay. So now you have got a lower motor neuron problem as evidenced by depressed reflex, symmetrical thick nerves. No? So you, at this point you will have to ask, it is clearly skin and the nerve, no thick nerve, everything is very clear. But you will have to know what are all the other neuropathies associated with thick nerves, palpable nerves. No? What all conditions? Even CIDP. CIDP over a long period of time, the nerves become palpable. Second, you have got Charcot-Marie tooth disease. You have got to the neuronal variety, you have got the axonal variety, that is type 1. Whereas type 2 is demyelinating type of Charcot-Marie tooth, where the nerves become palpable, but they will not be beaded. In Hansens disease, nerves are palpable and beaded. Whereas in demyelinating type of Charcot-Marie tooth, nerves are palpable, but they are not beaded. Second, Digerin sota. Digerin sota, the nerves became very big, but they are not hard, they are compressed. So it is typically described as soft succulent nerves, juicy nerves, soft large nerves which can be compressed, succulent, soft succulent nerves. So that is palpable nerves you get in inherited neuropathies, you get in CIDP, you get in amyloidosis, no? And you get in Hansens, then you get it on this HNPP, hereditary tendency for pressure palsy. Hereditary tendency for pressure palsy, also you get thick nerves. Amyloid, you get thick nerves. So these are some conditions with thick nerves, but these patches present confirms that it is only Hansens disease. So how will you confirm your diagnosis? Clinically itself, it is confirmed only, I think, no? Still, what are the things you will do to confirm the diagnosis?
Yes, ma'am. One is, if there is, we can take a biopsy from the from the skin patch.
When the skin is involved, no need to go to the lab. You can take the skin only. What other things? It is your area, no? Earlobe, all those things you will take. Earlobe.
Split skin smear.
Then, if the skin lesions were not there, what are all the preferred nerves which are biopsied?
One is
radial cutaneous branch. That is very important because that was described by Indian Gauri Devi Madam. No? So that is first that yield in the upper limb type of Hansens, you go and take biopsy from the sural nerve, you will not get anything if the lower limb is not involved. So radial nerve in the upper limb was introduced by Gauri Devi Madam. So how you take is you just do this thing in the extension, big top, no? And you find the anatomical snuff box. This anatomical snuff box, and you put your finger across your extensor hallucis longus tendon. Just put your finger across. As you reach the posterior part of the anatomical snuff box, something is obliquely rolling. Can you feel it? Yes, you can feel your own nerves. That is the dorsal cutaneous branch of the cutaneous branch coming from the dorsal branch of the radial nerve. So you will just extend like this. That's what we do. And you can put a quadrangular block. You split the skin here, reflect it, and you will see the nerve like a hair. But if it is Hansens, it will be thick. It is like this. It is obliquely crossing. If you just put like that, you are rolling. I am rolling my nerve. Now you can roll your nerve. And that nerve can be biopsied. Then ulnar cutaneous branch beyond the pisiform bone. There also it gets thickened. So pisiform bone is here. So there you will feel it. You can just superficially cut a small branch of the cutaneous branch of the ulnar nerve, just beyond the pisiform bone. Or it's a superficial branch of the common peroneal nerve. Supposing it is vasculitis, you have to take the superficial peroneal nerve. Or demyelination, you take the sural nerve. Or Hansens disease, over the neck of the fibula, a cutaneous branch of the common peroneal nerve, which is more vulnerable for Hansens pathology. So that nerve can be biopsy. So you can do the nerve biopsy, you can do the muscle biopsy, you can do the skin biopsy. Then you can look for the specific antigens, higher and higher markers. AFB may be there. If AFB is not there in all the types, you will find the thickening, connective tissue proliferation, inflammatory infiltration, and you can do immunological tests to look for the antigen antibody reaction in the nerve to the leprobacillus. Then you can do the imaging of the spinal cord and the brain. You may have lesions. This person is quite long duration disease, 1 year. So it is demonstrated granulomas, leprous granulomas can happen in the brain and the spinal cord. So that you can do. So this looks like probably it is intermittent, borderline type.
Borderline leprosy.
So how are you going to treat? Olden days during the British era, it is said that these people will have to go out only in a particular time, and they are supposed to carry a bell. So they will, others will not come out. Those stigmas were removed later. These were introduced during the British time. Later, these leprosy homes were introduced. Domiciliary treatment like tuberculosis. No? It's a long story. Then how are you going to treat? Now this person is not having any contractures. No? So to see that patient does not, it is skin plus nerve. So when you treat, you should not introduce contractures. That part you have to, when healing, they may go into clawing. So you have to add some immunosuppressants in addition to disease modifying drugs. So now there are no contractions that has to be taken care of. When the nerve is involved, steroids are added so that you do not get contracted during the healing process. And the duration, now you have got polytherapy, no? So many drugs.
Like
what all?
We're into like possibacillary and multibacillary. For multibacillary, based on skin lesions, if it is more than equal to 6 skin lesions, or any thickened nerves, or if the bacilli is positive in the biopsy, skin smear or biopsy, then we can consider it as multibacillary. For multibacillary, it is going to be for one year. So it is going to be a combination of rifampicin, clofazimine, and dapsone. Whereas for possibacillary, we don't add clofazimine. It is just rifampicin and dapsone.
What is the problem with the clofazimine? Pigmentation, photosubstitute. So they become dark. Then tell all the treatment.
Then for this is like has to be continued for 12 months here, and because we had the biopsy that was proven having the bacilli, lepra bacilli was positive. Whereas for possibacillary, it is going to be only rifampicin and dapsone. That is given for 6 months. 6 months.
Rifampicin is monthly, no?
Monthly.
Not daily, no.
No. Once a month, it is going to be like on day one, like first day of the month, or any one day of the month, is going to be rifampicin 600 mg and 1 tablet of clofazimine 100 mg. And then daily for the next 28 days, patient continues dapsone in possibacillary. Whereas in multibacillary, it is going to be on day one, it is going to be rifampicin, clofazimine, and dapsone. Rifampicin is going to be 600 mg. Clofazimine is going to be 300 mg and 100 mg of dapsone. And then for the next 1 month, it is going to be clofazimine 50 mg and dapsone 100 mg daily.
Okay. You have got so many reactions, no? What are all the reactions you are described in leprosy?
One is the lepra reaction, this type 1 and type 2. This happens whenever the patient's immune response improves. So because once the treatment starts and the immune system improves, there is going to be, because of the increased immune response, the patient starts developing multiple skin lesions, and the patient develops papulomacular lesions, which is called as like erythema nodosum leprosum reactions. They can develop the skin lesions. Like those kind of situations, like you can go for steroids at that time.
Any other reaction? You got upgrading, downgrading, Fitsuda, Fernandez reaction, Mitsuda reaction, no? All these things are there, no? Ahead of all these reactions, Mitsuda reaction, Fernandez reaction, upgrading reaction, downgrading reaction. So many things are there. All are immunological only. Whereas Mitsuda reaction is just a hypersensitive transient like a Mando. Whereas Fernandez reaction is alteration. So there you introduce steroids. Upgrading and downgrading is transfer of one type of leprosy into another type. No? Then you heard of Lucia leprosy and
it's like a vasculitis secondary to Hansens.
so it can. So that
patient is not taking medicines properly, then it may develop.
Norwegian scabies is scabies plus leprosy. That is Norwegian scabies. Whereas Lucio leprosy is scleroderma-like skin lesions teeming with bacilli, highly infectious. The skin becomes scleroderma-like appearance due to infiltration with infection. Those are the things. So still Hansens disease is there in some parts of our country. So, okay.
I think fourth case in about 3 months, we are seeing fourth or fifth case.
In Kerala, we don't see whether they are there and taking treatment in hiding, we don't know, but it's not there. But I have seen when I was in NIMHANS, I have seen, Tamil Nadu also I have seen. Here I don't see. Okay. There are specific cell-mediated immune deficiencies, so toxin deficiency or something like that, no? What are all those things, sir? Did you update toxin deficiency like that? This is a specific, so everybody exposed will not be getting it. Those who are the specific cell-mediated immune deficiency are prone for that. That may be prevalent in some parts of our country. So already biopsy is done now.
Yes, ma'am. Skin biopsy, punch biopsy of the skin, ma'am. That showed stain positive for mycobacterium leprae.
So you started treatment?
Yes, ma'am. You have started treatment. Other thing was the skin lesions that she had, ma'am. She said this, like she had obvious skin color change. That was like main symptom she said was this and that. Like,
that is hypopigmentation.
Hypopigmentation, you can call it like.
Yes, many areas of hyperpigmentation is there.
Yes.
Okay. Next, anything else?
This one, NCS was showing sensory motor neuropathy, demyelination of the.
We could get snaps, huh?
Ma'am?
Sensory motor may be there,
Yes,
but which is the severely involved. History-wise also it is small fiber, no?
Yes, ma'am.
So electrophysiologically, I am expecting that the snaps may be absent and motor conduction may be delayed.
I didn't check for it. I didn't see that.
That is the pattern you saw. That's what you see in Hansens disease. Snaps will be absent. Sensory action potentials will be absent or very much delay, and motor action potential may be delayed. Like that. That's all. For interest sake, you can study the upper motor neuron also. You can do an imaging and see whether this.
MRI of the spine was done. MRI of the spine was normal. And brain and spine, the whole screening of the whole spine was done with MRI.
No lesions.
Normal, no lesions.
Okay. Okay. And straightforward case only. Anyway, we learn how to go systematically, I think.
Yes.
If you go systematically, hardly you miss anything. Do not miss. Systematic approach is most important. Still, we will miss in a small percentage of cases. They are the tough cases which you will have to investigate. Otherwise, most of the cases follow the clinical pattern, you will get the diagnosis. So good, but most important is a good history.
Approach, yes, ma'am.
You have done properly, very good. You have taken a very good history.
Like, it's realizing more and more after attending your classes, like how important history is. Incidental lesions on the MRI, just say something is there on the MRI. But
yes,
it may not even be significant to that patient's symptom.
So why it is important? Supposing you don't see this and you see the MRI and find some lesion, somebody reports it a demyelination, you put the patient on steroids, thinking it as a demyelinating lesion in the spinal cord. We have seen such cases like that. So it's important that what is causing the problem and what is there in the shadow may not be the same. What is in the shadow may be a silent incidental one. Neurology is mathematics only. That is why the God has created nervous system with so much of mathematics skill. Every time I read again and again, I get excited. You could read that Akinator read Think you could enter, huh?
No, they didn't give access to it when we registered, but we're not able to access.
You have to go down and enter into the video. After you register,
Yes, ma'am.
log into the video, like that one option will come.
Okay.
Into that you
Didn't come.
after you register, down you will see log into the video. But it will be today will be the last day, I think. Then
we'll say it today.
You have to register. Anybody in the medical college gets in.
Yes,
After that,
you shared it with everyone, all colleagues.
Don't go into the video. Next, you have to click into the video login. Then only you'll get it.
I'll definitely watch it today.
That's just to know that most of the symptoms you get in extrapyramidal disorders have a scientific basis, like what we are discussing. Like paresthesia, dysesthesia, there is a mathematical relationship with each symptom. That part is highlighted in that presentation. So that will make you really understand neurology's mathematics only at all levels. So good. Shall we close?
Yes, ma'am.
Any doubt there?
How can we distinguish from a central cord lesion? It may also present similarly to bilateral. They can develop if it develops at the level.
Will present with a suspended dissociated anesthesia. So in this patient, the upper limb, I thought you have to consider a suspended lesion. Lower limb, it was a symmetrical lesion.
Right.
So central cord lesion alone without peripheral nerve will be just suspended and dissociated. So in this patient, peripheral nerve is definitely involved. That was the first symptomatic one. Central cord will be just suspended and dissociated, descending. Suspended, dissociated, descending sensory loss. Whereas peripheral nerve is ascending. It may be dissociated or it may be all fiber sensory motor depending on the type of disease. And it will be ascending. Whereas central cord is always suspended, dissociated and descending. Like that. Any other question is there?
No, there are no more questions.
Good, very good history you have taken. Good. You have to spend really time with the patient. Once then history is done, rest is very fast.
After this, realizing how important it is with history as well as examination. Peripheral thickened nerves, routinely was not in the habit of doing it.
After nervous system examination ends by skin, hair, nail, tongue, teeth, tonsil, spine, peripheral nerve, skull. This is what my teacher has taught. Skin, hair, nail. So look at the skin, look at the hair, look at the nail, tongue, teeth, tonsil. Then spine, peripheral nerve, scalp. Because I have written an article on skin and hair and nail as a clue to neurological diagnosis. It will be in the research gate. Scalp, you see, there is one Narasimhachari's photo in Madras Medical College. He is an Ayurvedic physician. He purchased the first EEG machine in India and he donated it to Madras Medical College. So his photo is there in the Institute of Neurology, Madras. So when he was considered as teacher of teachers by big neurologists like B. Ramamurthy, neurosurgeons. So one patient came with seizures. Those days, no, not much other investigations, they're long back. B. Ramamurthy's time when the institute started. It's the first institute in India in neurology, long before AIMS or NIMHANS or PG or any institution, Vellore and Madras. So that time, Narasimhachari sir came, it seems. And Tamilians are sentimental about stories and all these things. So he just routinely did a imagine Ayurvedic physician, neurological examination and palpated the scalp. And he found a depression because this man was a bearded lot of hairs. And it was a depressed fracture which was producing the status in that patient. If you have not palpated the scalp, you would have diagnosed encephalitis. No history is there, you see. Those kind of things, people transmit these stories and his photo is there. So another thing, there is no need to discriminate between the systems. All systems teach us. Only thing we should not do malpractice. What you do not know, you should not practice. You should not practice Ayurveda or Homeo, and they should not practice allopathy. Because it is impossible to study even one system. But we should respect all systems are equally important, and this story is to be told. He palpated and he gave the diagnosis. There was a nipple fracture. You see.
What is it like integrated? Is there any chance to like integrate two systems of medicine, bro?
See, that and all is wrong, because it is done by people who do not understand that 10 janmas are not sufficient even to study a fraction of the human body. You are doing medicine, which is much more tough. We did neurology, which is little more smaller. But in that neurology, everything consumes so many lifetimes. You take a dementia, in the dementia FTD alone, so many spectrums. So it is impossible to integrate anything, then you will produce quacks. Already there are enough quacks, terrible quacks. I think because of this pre-NEET era, anybody who had money purchased degrees. And it is a terrible havoc, unimaginable. You go to a hospital 24 hours, you have to pray that you are taken to the right person. Otherwise, you do not know who is who. That pre-NEET era, candidates from so many private colleges, no? That era has to go. It is terrible. If you go out only, you will know what is happening. They don't know what they are writing, what they are doing, what is it, nothing. So then there is one Shanai sir. He is saying that in previous janmas you might have tortured that person. So now that person is coming in the form of a doctor to torture you. That may be the secret of creation. Such people we do not know. So that is all. Everything is correct in creation. Don't argue like that. Sir will say, but you have taken the noblest profession and you have to be very careful in handling other people's lives. You cannot, it's terrible. You cannot edit them also. If the alphabet is not known, then how you read the letters, words? Unless you know the alphabet, the words cannot be learned. So that's a lost group of people are there. Very dangerous. So linking all systems means it is equal to waging a war on the society and killing them. That's all. That should not happen. So thank you. We'll close.
Okay. Yes, ma'am. Thank you so much.